So this is where we left off. We were just kind of going over the feedback loops that regulate follicular development. And I ended by pointing out that the event of ovulation is not as tidy as you might expect. It's pretty violent. It leaves behind a scar on the ovary. And then interestingly, instead of immediately turning into collagen, that scar becomes a temporary endocrine structure that only a while later turns into collagenous scar tissue. So the ovary just doesn't follow the rules of exocrine or endocrine secretion very closely. It's a really interesting structure from that perspective. It's always fun when something breaks the rules. Okay, so now we're going to move on to the uterine tubes and the uterus. And I'll show you some more examples of this as we move along. But I do want to point out that it's a common misconception that the uterine tube is right up against and wrapping around or in some way directly connected to the ovary. And that's not actually true. They're illustrated like that because they are close to each other. But if you were to zoom in, there's no tissue connection between the fimbriae and the ovarian covering, which means that when ovulation occurs, it's most of the time the ovum and its granulosa cells that come with it do enter the infundibulum and then make it into the rest of the oviduct, but sometimes it just ends up somewhere out here. So that in and of itself is interesting because you would expect there to be some kind of direct connection and there simply isn't. Unfortunately, that creates the possibility for ectopic pregnancies occurring just in the pelvis. Most ectopic pregnancies occur in the tube, but sometimes you'll have a pelvic pregnancy. They're very rare, but they have occurred. So the goal of the uterine tubes is to catch the ovulated oocyte and also provide a location for fertilization. So this always floors my beginning biology students because they all think that fertilization happens either here or here, when in reality, in order for everything to be timed correctly, fertilization should be happening in the uterine tube. And then as the new individual bounces down the tube, it goes from being a zygote to being an embryo that's capable of implantation. So that's kind of the idea here. And that means that not only does the uterine tube have to be sort of a welcoming environment for ova, but it also has to be relatively welcoming for spermatozoa in order for all of this to work. And as you can see from the cross section here, there is a bunch of opportunity for spermatozoa to get lost in these mucosal folds. So again, congratulations to all of you and to me on being the product of the sperm that most successfully avoided all these obstacles. Oh, so yeah, apropos of your comment, yeah, no, absolutely. Like if you've never really thought about it or didn't have the exposure to the information, why would it occur to you that that's how ectopic pregnancies might happen? But once you see it, you're like, oh yeah, that makes complete sense. So we'll look at a closer image of the uterine tube in a little bit. Like I said, ectopic pregnancies are way more common in here, oftentimes because the oocyte, once it's fertilized, just kind of gets stuck in one of these crevices and fails to move into the uterine lumen. So that's the usual type. So the reason it says ectopic parentheses tubal is because that's what it's called when it's in the tube. There's also pelvic pregnancies, which are ectopic in that they're not in the correct location, but they're not in the tube. They're just free floating out here. And as you might imagine, this is not a good place to build a placenta, so it doesn't tend to work out. Although if I'm not mistaken, and let me fact check myself real quick, I believe there is some medical history or evidence of pelvic pregnancies actually happening to work out. Let me check that. All right. So if there's a blockage or if the oocyte gets stuck, embryo doesn't get here. And obviously that's not a good place. And because of how vascular this area is, if you look closely, you can see that embedded in the broad ligament are a bunch of blood vessels. This can cause rupture and potentially fatal hemorrhage. So it's a very dangerous thing to have happen for the person experiencing the tubal pregnancy. Tubal ligation is essentially the same procedure that I described for a vasectomy, where you just cut the tube and tie the ends off, except the location of these tubes is much less superficial than the vas deferens. And so the tubal ligation surgery is a much more invasive procedure. For a while, there was a procedure called Essure, Essure, which involved the placement of a little kind of spring dealy in the tube, but that ended up being subject to a bunch of class action lawsuits because inflammatory responses to the Essure caused it to fail, or the spring would just kind of migrate around and go places where it shouldn't. It caused all kinds of problems. So I believe it was recalled by the FDA. So here is the relationship between the uterine tube and the ovary. So there's like a little sort of stem-like mesovarium, and it's connected to the mesosalpinx, which is that middle zone, and then right on up to the uterine tube. And then the isthmus and infundibulum sort of fold over like so. The infundibulum is nice and broad, and it's tipped with these little thingies called fimbriae. That's plural. Fimbria is singular. And these are interesting because they are vascular and they have little arteries in them. And these arteries pulsate with the rhythm of the heartbeat. And that generates fluid vortices in the pelvic fluid, which help to draw the ovulated egg into the infundibulum more deeply. So there's a little bit of fluid dynamics at play here. So the mesosalpinx is the superior portion right here. It goes from the mesovarium to the tube. And the ovarian ligament just holds the ovary in place so that it's not, for lack of a better word, sort of flapping around in there. So all of these structures are held in place by a series of complex ligaments. But the ligaments are flexible because obviously the position of all this stuff has to kind of change in the event of a pregnancy. So the suspensory ligament anchors the ovaries to the pelvic wall, and they contain artery, vein, and nerves. And the mesovarium anchors the ovaries to the broad ligament. So there's all kinds of anchors to hold everything in place. And assuming all that goes well and has formed appropriately, the majority of ovulations should make their way into the tube successfully. It is muscular, the oviduct, so it does involve some small amount of peristalsis, and then the cilia are actually doing the bulk of the work inside the tube itself. They're not always active. They are activated parasympathetically according to the hormonal rhythms of the ovarian cycle. So they turn on around about the time of ovulation to start bulk fluid movement towards the uterus, which is interesting. So here's the wall of the uterine tube. And as you can see, there's alternating layers of smooth muscle. So circular stands for circular, so wrapping around the tube, and then longitudinal stands for longitudinal. So we're just kind of going back and forth here. And then you can see this peppery appearing tissue is the lamina propria of the uterine tube mucosa, and the mucosa itself is thrown into numerous mucosal folds. Now, the cilia are not super visible on this, but they do have them. And then that degenerates into just regular columnar epithelium later on in the tube. So let's talk about endometriosis. We'll look at endometrial tissue later. endometriosis is basically the growth of uterine lining tissue, not in the uterine lining. The reason we're mentioning it here is because the oviducts have a direct connection to the uterus itself. And so they're a frequent location where you find this sort of rogue endometrial tissue. The endometrium itself, as we will discuss, is very sensitive to hormones. So the whole reason that it grows and becomes glandular and then sloughs off about every 28 days is because it's responding to estrogen and progesterone. So what that means for people who suffer from endometriosis is that as their hormone levels change monthly, not only does the endometrial tissue that's inside the uterus grow and slough off, but so does all the endometrial tissue that is at random locations throughout the body. Bummer. So that causes pain. And if the endometrial tissue is concentrated in the tube, it can produce adhesions and scar tissue, which may block the passage of eggs or the product of conception and cause infertility, just because there's no way for the embryo to move through the tube. Okay, so this chart looks complex, but you can really break it down as follows. So for some contextualizing information, in response to increasing pulses of GnRH from the hypothalamus, we see those increases in FSH and LH, right? So FSH during the initial phase is going to literally stimulate the ovarian follicles to grow. And because we have more and more granulosa cells as the size of the follicle increases, you can also see that the amount of estrogen increases corresponding to the size and number of developing follicles. So it's just proportional to how many granulosa cells there are. So in the early stages, FSH secretion is outpaced, and LH remains relatively stable because remember, we are making it, but we're saving it up in the pituitary so that we can do this big LH surge. So around day 13 or 14, you see the LH surge, and then that is what causes ovulation. And then after that, you have this nice inflection point here. Oops. And that is because the scar left over from ovulation. So this thing is going to go cruise down the tube and either get fertilized or not. But then we have this corpus hemorrhagicum, which is the bloody scar on the ovary after ovulation. And that turns into the corpus luteum, which produces primarily progesterone. It also produces estrogen, just not as much. Progesterone is the primary hormone of it. So what does this have to do with the uterus? Very, very early in the cycle, at the end of the menstrual phase, is when the whole situation is resetting. And then during the proliferative phase, and you can see this is where estrogen is dominant, the proliferative phase is driven by estrogen. So estrogen is causing two things to happen. One is the endometrial lining is thickening, so it's getting broader and deeper and more vascular. The other thing that you don't see here is that estrogen has a permissive effect on progesterone. So what that means is also during the proliferative phase, estrogen is acting on these cells to cause them to express progesterone receptors. So estrogen causes the endometrial tissue to be extra super sensitive to progesterone later in the cycle. And as we can see here, after ovulation, when progesterone really gets going, now the uterus is extra sensitive to that progesterone. So during the secretory phase, it experiences much more rapid growth due to that progesterone sensitivity. And then if no pregnancy occurs, then there's no signal to keep the corpus luteum. So progesterone and estrogen decline, and that decline causes rhythmic constriction of these spiral arteries, which produces ischemic endometrium and then apoptosis and sloughing. So added note is that here we have ovulation, and then after this, we're just taking a break from thinking about what the egg or product of conception is doing. But you can think of the uterus as being like a very specially timed catcher's mitt for an embryo. So essentially, this last push is the last effort to prepare to catch whatever's coming down the tube as it bounces its way down the tube, which takes a few days. It takes between 3 and 4 days. So hopefully by the time, if a fertilization occurs, by the time it arrives from the tube in the uterus, the endometrium looks something like this. And also hopefully the embryo has proceeded to a developmental state where it is capable of implantation. So the timing of pregnancy and implantation could not be more important. All this stuff has to line up. Fortunately, mostly it does, but hopefully also what I'm impressing upon you is that there's this delicate and complex time-based dance that the ovary, the uterus, and an embryo is doing, and they all have to align correctly in order for successful fertilization and implantation to occur. That's also the reason why the vast majority of people with ovaries and uteruses, if they have intercourse with the opposite sex, at some point in their lives, most people experience a spontaneous abortion and are typically unaware of it because the product of conception, in that case, the embryo, is so small that it just sloughs off with the connective tissue and endometrium, and it's never noticed. So let's talk about the uterus itself. It's really small. So there's not really a good context here for how tiny it actually is when it's in the refractory period, aka not, carrying a pregnancy, but it is little. It's smaller than your fist. The fundus is the top domed portion. The body is the middle, and then the cervix is this neck-like portion that sticks down into the vagina. And the cervix is kind of its own deal for that reason. So you can see it's kind of like it looks like a funnel fitting into a tube almost. And there's an internal and external os, which is just the fancy word for the orifice. And much of the time, the area between the internal and external os of the cervix is full of a mucus plug. And this mucus plug becomes extra dense and thick during pregnancy just to seal off the uterus from the external environment. Some methods of birth control actually artificially thicken the cervical mucus, and one of their modes of functionality is to basically keep the mucus plug thick enough to not admit sperm during intercourse. For example, the Mirena IUD, which is a little tiny plastic impregnated with hormones that sits in the uterus. It releases small amounts of estrogen orthologs that not only affect ovulation, but also keep the mucus plug in the uterus quite thick so that sperm can't get in. It does both things at the same time. And a lot of hormonal birth control does both things at the same time. So there's also cervical glands that secrete that mucus, and you really only find them sort of in the submucosa of the cervix here. And they're special in that they're different from the uterine glands, because the uterine glands are all about endometrial action, whereas the cervical glands are really all about that plug. Okay, so what do the layers look like during those different phases? So here we have the proliferative phase. You can see the muscularis here, and then if you look closely, you can see the little line between the muscularis and the endometrium. This is the basal layer or stratum basalis. This is the regenerative portion, so it contains stem cells that give rise to what's above it. As you can see, we've got places where, especially like right here, it's relatively thin. You'll also notice that the glands here are pretty straight. And the distance between glands, so like this one and this one, this one and this one, is pretty wide. So there's lots of stromal cells, which are just the cells filling in the interstice. As you move into the secretory phase, we have growth increasing. And this is secretory leading into almost implantation status. So what happens at this point, and you can't really see the spiral arteries very well in here. These are glands, but if we were to move closer, you'd be able to. When progesterone gets underway, the growth is so fast that the glands do not keep up. So they get bunched up, which is why they appear spirally here. This is the ideal situation for implantation. We got a nice, thick, very glandular mucosa. The glands produce something that's kind of gross sounding called uterine milk, but it is important. It's a glycogen-rich secretion that provides nourishment for an implanting embryo. And then the blood supply basically begins coupling with the embryo if an implantation occurs to begin forming the placenta. So let's say no implantation occurs and progesterone and estrogen levels are declining. You start to see changes structurally to the endometrium. So those constriction of the arteries produces ischemia and hypoxia, and that causes the glandular tissue to dissolve. The spiral arteries break off and the stromal tissue breaks off as well. And you can see it's beginning down here. So a lot of this pink stuff is blood from the spiral arteries breaking off. So when, especially in America, because our sex education is not that great, when young people are taught about menstruation, especially if they're taught about it by someone who is not an expert, the stuff that comes out through the cervix and vagina during menstruation is often referred to as blood. It is absolutely not blood. It includes blood, but it also includes stromal cells, glycogen-rich secretions, mucus, clots. It's tissue. So it varies in not only consistency, but also color and appearance, which if you were never told that and you experience a menstrual period might be somewhat alarming, I would imagine. Okay, so this is a nice summary slide. It talks about the stage of the cycle and just discusses what the ovary is doing during that time, what the pituitary hormones are doing, and how all of these things are related, which is really nice. So I would keep this on hand just to remind yourself, in addition to that chart previously, how all of this relates. Okay, so the cervix, we mentioned that the cervical glands were a little bit different and produce mucus. The cervical mucosa and tissue is also different. So the cervical canal itself is continuous with the endometrium, but it's not the same as it. So it's not as thick and it doesn't respond as dramatically as the body or fundic endometrium. And it's got these numerous cervical mucus glands, which are indicated by the arrows all over the place. And you can see their lumen size is large. So at the external os, we get this transition from columnar epithelium to stratified squamous epithelium, marking the onset of the vagina and the covering of the what's called the exocervix, which is the outside portion, so not the cervical canal. So exfoliative cytology, it refers to taking a sampling of the exfoliated squames from the surface of the cervix, and that is known as a pap smear because it was developed by a guy named Dr. George Papanicolaou. If you're not familiar with a pap smear, let me describe the procedure to you. A very small, it looks like a mascara brush or a tiny toilet brush. A very small little bristly thing is basically scraped across the exocervix to gather up these squames, and they are then stained and examined for abnormalities. It's a very uncomfortable procedure, and for some reason, nobody finds it necessary to administer any manner of anesthesia during it, nor do they find it necessary to do that for IUD placement, just FYI. So there's obviously some medical sexism at play there. But it's an important procedure nonetheless, because due to the regenerative and exfoliative nature of the exocervix and its proximity to the outside and possible teratogens, early detection of cervical cancer is really important and also will dramatically increase the survival rate. And it's really only observable if you get regular pap smears if you have a cervix. So what they're looking for is weird keratinization or funky nuclei that don't make sense in the squames. So that's kind of what they're trying to find. So epithelial dysplasia and metaplasia, remember, is a change in morphology to the epithelial cells. Now we have an HPV vaccine, which can be administered in adolescence or childhood, and which effectively prevents HPV from taking hold. But that was a relatively recent development. And so the most common cause of cervical cancer is human papillomavirus, the major predisposer. You can, of course, develop cervical cancer without having HPV, but this is much more common. And to dispel another common sexual myth, the number of people who have HPV far outnumbers the number of people who actually manifest genital warts. So most people who have HPV are asymptomatic and probably don't even know it. So that's the main reason for the vaccine, and also a reason just to destigmatize that whole thing, because it's way more common than we once imagined. Interestingly, and this is a subject of a fair amount of research if you want to have a stroll down Google Scholar, the mucosa of the endocervix is actually host to a lot of microorganisms. And these are considered to be related to the vaginal flora, which are a normal part of vaginal health. But because there's, stuff there that it needs keeping an eye on, you will also see neutrophils. So here's one, for example. Yeah, these are all neutrophils. Look at their nuclear morphology. So these neutrophils are here to just kind of monitor the bacteria and eat anything that gets where it's not supposed to be. All right, so after the exocervix, we've got the vagina, which is basically an elastic muscular tube lined with an exfoliative stratified squamous epithelium. And similar to the relationship between the dermis and the epidermis, there's little papillae of the lamina propria that poke up into the epithelium. So the margin between the two is not necessarily a straight line, it's wavy. And then down there we have a muscular layer, and there's a lot of elastic tissue in here as well. So there's bundles of smooth muscle arranged in a circular manner, and also longitudinally. So we have a mixture, although you're really mostly seeing the circular layer here. So let's talk about aging, because we're all going to do it. And as we all know, there are changes to sexual morphology with age in both males and females, both people with vaginas and people with penises. As we discussed previously as well, maintenance of secondary sex characteristics, so not gonads, is mediated primarily by sex steroid hormones like estrogen. So what can happen in postmenopausal people, and again, this is a small error, we'll change that. So postmenopausal people might experience this essentially because there's no more follicular phase of the ovary, estrogen levels tank, and this can cause a variety of problems. But one of them is the epithelium is not as well maintained. So there's not as much cell turnover, and all of this stuff kind of gets thinner. So this produces changes in sexual behavior and experience, and it also can predispose one to more frequent inflammation and infections. So more care needs to be taken when maintaining this structure after menopause. You can get vaginal cancer due to the primary squamous cells, so the stem cells down here, like, I'm going to divide weirdly. That's what I decide. But typically it doesn't start in the vagina. It starts either in the cervix or in the vulva. So the weird cellness is either beginning externally or beginning internally. It's not usually originating here. Okay, mammary glands. These are interesting. So the mammary gland consists of a fat pad with potential glandular tissue, but glandular tissue which is refractory in the absence of the hormones of pregnancy. Fun fact about the lactiferous sinus, before we go on to the rest of this, now that we have advanced imaging of the breast tissue, it appears as though the lactiferous sinus, which has been described previously in pretty much every breast anatomy picture that you'll find or see, it's not present in the same way in medical imaging of living breasts. And the theory on that, or the hypothesis anyway, is that the old way to resolve these structures was to inject liquid latex or wax into a cadaverous breast. And the theory is that that liquid latex or wax just backs up here because of the resistance of entering a duct and produces this artificial swelling that is not reflected in healthy living breast tissue. So this is actually a structure that's being debated in the medical literature currently because of old versus new techniques of dissecting and resolving what structures are in here. So always be checking the primary literature is the lesson there, because a thing you think exists might not. So before pregnancy, the gland is inactive because you don't need to be feeding anything. It is possible to have lactation occur absent a pregnancy, but it's rare. In response to the hormones of pregnancy, so consistently high estrogen and progesterone, the alveoli begin to develop. And then by mid-pregnancy, we've got all kind of the makings of it, but we're not making milk yet because there is not yet a neonate to feed. So among the hormones involved in parturition are activating hormones that basically wake up the breast tissue and say, all right, baby's here, time to feed it. And this can begin before parturition as well. So they don't always perfectly align. Lots of people will begin lactating shortly before they give birth, not uncommon at all. And then after that, essentially, continued stimulation of the breast maintains the lactiferous apparatus. So weaning is really the stimulus for it to degenerate. It's, the time-honored use it or lose it principle. If there is no stimulation of the tissue will become atrophic and the breast returns to a refractory state until the next instance of feeding. So the nursing action of the child, and I recommend watching, there's like x-rays and MRIs of this, that you can watch. The infant, they're not like delicately sucking on the nipple. Their little mouths and tongues are designed to basically grab a mouthful of areola and pinch off an area and then suck the milk out of the area mouthwards of the pinched zone. So it's an involved process, which explains why some babies have difficulty with what's called latching, which is doing that properly and feeding properly. So that's where you would get a lactation consultant if the baby was having a hard time latching and or there is an issue with milk letdown. So there's baroreceptors in here that basically are connected to the posterior pituitary and hypothalamus and cause oxytocin release, which causes milk letdown, which is not the same thing as the action of prolactin. Prolactin is involved in preparing this apparatus. Milk letdown is smooth muscular action, which moves milk from the glandular tissue towards the nipple. So breastfeeding is a team effort between both neonate and parent. Another reason you might need to get a lactation consultant involved is that oxytocin, in addition to being a lactating hormone, is also a mood hormone. So positive, affiliative, loving feelings are associated with increased oxytocin, and the opposite inhibits oxytocin and can really shut down the breastfeeding reflex, which is why we as a society have implemented things like lactation rooms. I know PSU has a bunch of them, so does Clark, my other work, basically just quiet places where people with new babies don't have to breastfeed in public, because that would, for some folks, trigger an emotional response that might preclude successful feeding. So this is what this looks like during pregnancy. As you can see, there's some big changes. So we do have all this stuff, but the glands really develop during pregnancy and lactation to become much more robust. And as you can see in the ducts here, we've got the colloid, which is milk. There's a question in the chat, is there any connection to the oxytocin release and postpartum depression? That I don't know. What I do know is that the mood altering effects of oxytocin, because of its chemical makeup and its release, are relatively short term as far as the amount of time oxytocin circulates and then is cleared. So it might be a combo of that and some more long-term changes with, serotonin and GABA and other neurotransmitters, but I don't know the exact answer to that. It's a good question. So let's talk about breast cancer, because we're looking at breast tissue. It's almost always epithelial derived, which shouldn't surprise anybody because epithelia are, very regenerative, which creates statistically more likelihood for, DNA replication errors, essentially. So usually it's a ductal carcinoma, which is when the ductal cells essentially begin invading the interstice, the stromal cells. And what they generally do is form a nodule that you can feel, which is why doing self-breast exams regularly to check for those things is important self-maintenance for anybody with breasts. And also important to note, let's bring this back up. People with quote unquote female anatomy are not the only people who can get breast cancer. So people with penises and testes can also get breast cancer. It's far more common in people with breasts who's, are going to respond to lactation in infants, but it's not unheard of. So it's not as binary of a disease as was once thought. So essentially just, if you have breasts of this nature, regularly examine them. And then if you find a lump, go get it checked out, because the earlier it's detected, the higher the survival likelihood is. We also got to talk about mastitis. So itis means inflammation and mast means breast. So mastitis means inflamed breast. This basically happens when an obstruction of the ducts is accessed by bacteria, and the bacteria are like, hooray, nutrients, and begin reproducing. And that produces inflammation, neutrophil invasion, and notably incredible discomfort in those who suffer from it. So if you go on, for example, pregnancy forums or new parent forums, the mastitis section is often alive with commentary from people who are like, please, I will do anything. Tell me how to fix this problem. It hurts so bad. All right, and then that concludes reproduction. So now, we're going to start with eye. And this is a nice sort of summary of what are called the tunics of the eye, which is the layers. So you have an outer, a middle, and an inner, and they all have their own specific functions within the context of the eyeball. So the eyeball is a very highly evolved light catcher, but it also focuses and changes the refractory angle of lights. And it's specialized to have structures that are avascular and see-through, transparent, which is hard to accomplish. So that accounts for some of the weirdness of the histology of the eye, which we will observe directly. So the outermost layer includes the sclera, which is the white of your eye, and the cornea, which is this anterior domed transparent portion. The middle is the choroid, which is pigmented and vascular and includes a muscular structure called the ciliary body, as well as our iris, which is the same thing as a camera's aperture, basically. And then the inner layer is the neural layer, and that's the retina. So we'll look at all of these. The lens, let's go back really quickly. The lens is this big transparent structure here, and it's actually made out of connective tissue. So it is cellular and it's comprised of living cells. So if you want to make a structure that is flexible and living, but transparent, you have a problem. And the problem is it can't contain blood vessels. Otherwise, blood vessels would be constantly overlaying your field of vision. Not ideal. So the lens and the cornea both are interesting because they manage to be cellular but avascular, and they rely on diffusion of oxygen and nutrients from the fluid that bathes them. So the lens capsule is a really thick glycoprotein-rich external lamina, which encompasses all of this. And then you have a small columnar epithelium, which essentially is between the capsule and the differentiating zone. So this is the edge. So you can see that there's these little guys, which give rise to these cells, and you can see the relative age by their proximity to the mature lens fibers. And as they differentiate, they begin making what are called crystalline proteins, which is what it sounds like. They're special proteins with special optical properties. And there's a zone of hypertrophy here before the zone where the mature fibers remain. And there's no nuclei here because these cells are undergoing apoptosis as they mature. So they basically become a mixture of collagen and crystalline proteins in the center here. Interestingly, There is variation in crystalline protein structure across vertebrate taxa. There's been some really interesting analysis of crystalline protein structure in the lenses of, for example, deeper level pelagic animals, so like shark eye lenses and whatnot. And so different animals actually have different amounts of lens clarity and lens refractive power, which is cool. So accommodation is the name for basically tugging on your lens or letting it relax to change how it's shaped. And that changes the angle that light passes through it to focus the light on a specific spot on your retina. So this is the side view, and then here's the anterior view. There's a ciliary muscle, which is smooth muscle, and it's attached to some ligaments, which attach to the lens. So these have a fun name. They're called ciliary zonules. They're also called suspensory ligaments, so you might see them referred to as that. So with near vision, so when you look at something close, the ciliary muscle, this smooth muscle, is going to contract, and that puts tension on the zonule. Which, oh, sorry, I meant distant vision. This is opposite. I just found an error in the PowerPoint. I'll have to fix that. When we come back, I'll have it fixed. But for now, if you look, we have taut zonules, and the lens is going to flatten. And then down here, we have relaxed zonules, which allows the lens to round. So as we age, the ability of our lens to change shape declines. And that accounts for the need for people to get reading glasses. So if you look at reading glasses and look at their lens convexity, there's varying levels of it depending on how bad. But the reason that most people as they age have changes in accommodation from near to far vision, so they don't really have much of a problem looking at far stuff, but they can't read close-up things anymore and need magnifying glasses, that kind of stuff, is because you're unable to allow your lens to change shape enough to focus on a close object anymore. So that accounts for the need for readers. It's not the same as cataracts or presbyopia. This is denaturization or denaturation of crystallines. So essentially those crystalline proteins that are produced during the hypertrophic and apoptotic stage in the lens begin to unfold a little bit with age. So it's similar to any other connective or structural protein that you would encounter. So collagen, elastic fibers. As we age, all of them decline in quality, which produces wrinkles and a stiff, inflexible lens and a lens that is less transparent than it once was. Cataracts are basically areas of the lens that become opaque. And these can also include, or cataracts can also occur in the cornea, but it's more difficult to treat them when they're in the lens because it's a deeper eye structure. The most common cause of this is excessive UV exposure or diabetes. Oftentimes diabetes and hypertension together will cause this. They're more rarely due to trauma. And not to be gross, but what I mean by trauma is penetrating eye trauma, or sometimes radiation. Okay, so I mentioned the challenges. Oh wait, there's a question. So the question is, once somebody develops myopia / presbyopia, is there a way to fix it? Not presently, because of the changes in flexibility. Of course, you can get a corneal transplant for some of that might address it. And we also have LASIK surgery, which basically changes the curvature of your cornea. But once the process of lens stiffening or opacity changes begins, there's not a whole lot you can do. So it's mostly just damage control. There is some successful sort of lens transplantation, but it's not a normal geriatric eye procedure. Also, because this is such a specialized structure and because it has limited access to oxygen and nutrients, the healing time and the healing requirements for such a surgery are really, really intense. And so the likelihood of that kind of surgery being successful in older individuals declines because they just don't have the mitotic capabilities to heal that a younger person would. So if you go to the ophthalmologist, for example, and ask them frankly, a lot of them will straight up tell you that like there's an age beyond which there's not a whole lot of a point in performing LASIK, for example. Okay, so let's talk about aqueous humor. Aqueous humor is a watery substance in the front part of your eye. It's not the same as what's back here. So back here is the vitreous humor. So you have two compartments in your eye. The front one is full of a blood filtrate that comes out of these little, there's a choroid plexus in here, which is a pressurized capillary bed, and fluid leaks out of it. The fluid flows, it bathes your lens. So hopefully these edge cells that are the ones that are still alive get oxygen and nutrients and dispose of wastes. And then the fluid flows out through your pupil into the anterior chamber and also bathes the cornea before being reabsorbed into the scleral venous sinus, which also has a fun name, the Canal of Schlemm. Schlemm being the last name of a guy. So this is supposed to be produced at the same rate it's being reabsorbed. If you have vascular abnormalities or issues where reabsorption is impaired, you can get glaucoma, which is basically a pathological increase in intraocular pressure. And then what that ends up doing is pushing everything back, and it pushes the vitreous body against the retina, and that can cause blindness if it's left untreated. So if you go to the eye doctor, as I was recently, some of you may have experienced this as well. You know the test where you have to put your chin on a little thing and then they have you look at like a picture of a little house, and then they aim a puff of air at your eyeball? You guys ever had that test? I do not enjoy the eye puff. It's really hard to keep your eye open when somebody's puffing air at it. The point of that test is to assess how much or little your cornea moves in response to that eye puff or that air puff, to try and assess intraocular pressure and corneal stuff. It's a way for them to avoid poking you in the eye. They just poke you in the eye with air, but that's what that test is for. So cornea has the same limitations as the lens, which is to say, we need a living, flexible structure, but we also need that living, flexible structure to be transparent. So accordingly, like the lens, it can't be vascular. Otherwise, you would have a constant overlay of blood vessels in your vision. But fortunately, the cornea is adapted similarly to the lens. So we have the external epithelium. These are a non-keratinized epithelium, and it has nerve endings that trigger the blinking reflex. So this is part of the reason why you can't hold your eyes open without blinking, without considerable effort. And when anything touches your cornea, you feel compelled to blink. The stroma is collagen fibers and flattened keratocytes. Again, avascular, so the aqueous humor causes oxygen to diffuse into this, which keeps whatever living cells alive. And then on the external surface, of course, there's oxygen ambiently that can diffuse in. So we've got oxygen diffusing from both ends. And then there is the little endothelial lining, which is very, very narrow. So I mentioned LASIK earlier. If you have either myopia or hyperopia, or in some cases astigmatism, although not all people with astigmatism are good candidates for LASIK. So it's possible to go to the ophthalmologist for an astigmatism and have them say like, I'm sorry, your corneas are shaped too weird and we can't do anything for you. So the shape of your cornea is supposed to be a dome, and it's supposed to be a circular dome to the greatest extent possible. But if you have like oddly pointy or conical corneas or a lopsided one, that can be an astigmatism. And you can change it by basically making a little flap and then displacing the flap and changing the curvature, and then it heals, and then basically you have built-in glasses almost. You still might be a candidate, actually, if you only have it in one of your eyes. It just depends on how extreme. For example, I have been told that I'm not a good candidate for it because my astigmatism that I have is not only asymmetrical, but it's not pronounced enough, which I was surprised to hear. But I've also heard LASIK horror stories. It used to be a lot worse than it is now. It's a much more advanced surgery now. So interesting. I wonder what happened with your dry eye. Interesting other application, I mentioned corneal grafts earlier. So if you have corneal cataracts for some reason, you can get a corneal graft, which basically they take a cadaverous individual's cornea and cut it out and then install it in you. And the reason that works is because of the lack of blood supply and lymphatic drainage. So they don't, it's a biologically inert structure, essentially. It's not unlike receiving cadaver bone or tendons, for example. Yes, you is right, but it's true. So what I'll sign off with is to tell you about a job that exists in Portland that's pretty good money. If it's nice work if you can get it. I almost did this during college. So it used to be called Lions Eye Bank, and now it's called Lions Vision Gift, as in Lions Club, the fraternal organization. They have offices in Portland, and basically you can pick between one of two jobs. And one of the jobs is you show up at a decedent's bedside after they've died, and you harvest their corneas so that the cornea can be given to somebody else. But because you have to do this before decay or embalming, you have to show up pretty much immediately after somebody dies or pretty close to it, which can be uncomfortable. The other job that Lions Vision Gift will offer you if you apply is sometimes they have you work the phone banks first. And in my opinion, that's worse because you have to call the family of the decedent and say, hello, very sorry to hear that Joe has passed away. But before he did, Joe did promise us his corneas. So I'm going to be coming by to cut his corneas out in a few minutes here, just making sure that you're aware of that. So perhaps the oddest telecommunications job one could have, but also really important and definitely saves people's vision and quality of life. So an important job. But if they pretty regularly post job postings, because as you might imagine, it has a fairly high rate of turnover and they pay really well. So if you're hard up for a job and you're not squeamish, consider doing that. Oh yes, and to answer your comment about the funeral home with the eye caps, yeah, we actually do that in the cadaver lab too. Basically it has like a a little, for those of you who don't know, little opposite facing spikes that poke up so that when you pull the eyelid down, the eyelid doesn't retract up. I will say, however, that in the cadaver lab, because we have them for so long, the tissue ends up contracting and then you can see the eyeball caps. And if I don't super glue the eyes shut, it really freaks students out. So it's kind of a lose-lose situation. You either see a dry eyeball or you see a spiky eye cap. Nobody wins.